Good evening to all of you. I try to keep the talk little brief and to the point. There are few take-home messages which I feel everybody should get by the end of the talk. So, without much ado, let's begin with the CT imaging and pulmonary venous anomalies. Now, most of these are related to congenital heart disease. Some of them you may see incidentally in an adult. Now, the common anomalies that we see will be an anomalous connection of the pulmonary veins to either a systemic vein or to the right atrium. Other anomalies would be a sinus venosus defect, which you often see in an adult incidentally. Isolated pulmonary vein stenosis, these can be congenital or acquired. Then pulmonary AV fistulas, which are quite rare, and pulmonary vein thrombosis, which is also not very common. So the most common ones that we come across in congenital cases would be anomalous connections. Okay. So the type of connections, we'll describe the type of connections first. So when we are describing it, we have to mention whether there is total anomalous connection or a partial anomalous connection. Total means all the entire pulmonary venous system is draining either into the right atrium or into the systemic vein. And partial is when all of them are not draining. Some are draining anomalously and some are draining normally. That is PAPVC or a TAPVC. Then the second thing that you described is whether it is where they are terminating. Are they terminating above the heart? So it could be supracardiac, which is terminating in SVC or the innominate vein. Or it could be cardiac, where they are draining directly into the RA or into the coronary sinus. Next is infracardiac, where they are draining into the IVC, hepatic vein, portal vein, and so on. And mixed variety, where they can have some veins draining supracardiac, some infracardiac, or any permutation combination. So these two things are there that you describe. And third most important thing is whether or not there is a obstruction to the venous system, because that greatly impacts the prognosis and whether the patient is going to go the surgery or not. That depends on how much obstruction is there. So these are the three things which you will describe in a anomalous venous connection. Now, usually these patients in childhood would present with cyanosis, difficulty in breathing, right heart failure. But most important that you have to remember is TAPVC can come as an emergency with acute right heart failure. These patients need to be operated immediately. So these are one of the rare cases where there is an urgent pulmonary angio required in a either a neonate or an infant. TAPVC, especially if it is obstructed, becomes an emergency. Associations now, we'll trace the flow of blood. Now, if you see a pulmonary venous anomaly, what happens is that all the blood from the lungs is entering, instead of the LA, it is entering into the RA. So there is overflow of a blood flow into the right heart chamber and reduced flow into the left heart chamber. As a result, especially with TAPVC, the LA is going to be small. Once the LA is small, the outflow from the LA into the LV is going to be reduced. And definitely then from the LV into the aorta is going to be small. So when this happens, the aorta may not develop adequately and it may come as a hypoplastic aortic arch or a coarctation, which is quite common with TAPVC. So you must look at the aortic arch when you're looking for TAPVC, whether the mid arch and the isthmus are of good size or no, because that is an additional finding which we will define the prognosis of whether the arch needs to be repaired or no. Next is common associations is right-sided isomerism and complex congenital heart diseases. These are associations, many associations with, especially with TAPVC. Now, what is the importance of imaging? Now, we all know it is vital for diagnosis, treatment planning, follow-up. Echo, mostly the diagnosis is made on the echo. CTs come for detailed anatomical evaluation for confirmation of the diagnosis on echo. And for planning, especially in TAPVC with a common chamber, we'll come to that later. MR is not usually utilized because most of the times the diagnosis is made on CT and we are not really concerned so much for functional evaluation. So MR is limited when you have a PAPVC patient and you don't know whether you need to repair the PAPVC or no. So we look for the amount of shunting. So when you want to measure the pulmonary to systemic flow ratio, That is where MR becomes important, and those are the cases who will be referred for MR. So we won't be covering MRI in this talk, but we'll cover the detailed CT findings. So why CT angio? Again, it is very quick, high resolution imaging for detailed evaluation of pulmonary veins, connections. Everything can be done very fast, very easily on the CT. Plus, you can look at the lungs, you can look at the tracheobronchial tree. That also I mentioned why it is important. So all the things that you need on CT. So CT is usually the next step after the 2D echo. Now the protocol. Usually we follow standard protocol. We inject in two runs. First run is ECG gated and second is non-ECG gated. So the second run which we take, we have to cover the upper abdomen. Because if you're looking for an infracardiac TAPVC, even or a mixed TAPVC, which you don't know before the scan, so it may end up draining much below the diaphragm. So you don't want to miss that. Plus, there may be anomalies like an Abernathy malformation or something. You don't want to miss that. So all congenital heart disease cases, the second run you must cover the upper abdomen. Okay. First run up to the diaphragm is fine. Second run is what you need to cover without ECG gating in the upper abdomen for a complete evaluation. Then VR images are also quite important when you're giving a TAPVC, so that a very good spatial representation of how the anatomy is will help the surgical planning. So that if you can give, it just adds value. So how do we go about the reporting? So first is to identify the morphological atria by the atrial appendages. Next, we have to trace the veins, where they are terminating. Are they supracardiac, infracardiac, mixed? All those things you have to identify. You must remember that it's no tributaries in the thorax except the azygous vein. So azygous vein we all know. So if there is any other vein which is draining into the SVC when it enters into the thorax, invariably it is going to be a pulmonary vein and you may be dealing with a PAPVC or a TAPVC. Next is you must check whether there is total anomalous connection or a partial pulmonary venous connection anomaly. Look for a common chamber. So I mentioned what is a common chamber. This is an important thing which you should remember. And check for pulmonary venous stenosis. This is also an important finding which must go in all reports. Now, first step is identifying the morphological atria. Now, this is a still image you have taken. This is a typical right atrial appendage by morphology. If you see, this is a triangular shape. My mouse is visible, I hope. Uh, so this is a triangular right atrial appendage, which you can see. And if you see the left atrial appendage, it is finger-like and long. It's more tubular. And also the pectinate muscles, you're not seeing them here, but if you do see, they are going to be perpendicular to the length, like this. Okay, so it's very important to identify the atrial appendages because then you will know whether they're draining into the correct morphological atrium or not. So first step begins with identifying the atrial appendages. So right atrial appendage is triangular, left atrial appendage is more tubular and finger-like. So this is an example which I'm showing here only to identify the atrial appendage. Now if we go scroll down, you see one appendage which is coming over here. Okay, you see a band which is coming into the along the into the atrial appendage, which is parallel to its length. Okay, this is the right atrial appendage. If we go down, we'll see that it is triangular. It has a wide opening along the atrial chamber. So if you see, this is a wide opening of the appendage. So this triangular structure is the right atrial appendage. And we go on to look for the left atrial appendage. If you see, this is more finger-like and more tubular in structure. So that's the left atrial appendage. It's like almost like a bent finger if you want to call it that. So this is the first step, identifying the atrial appendages. So then we go on to our cases. Okay, so this is the first case of partial anomalous pulmonary venous connection. Now this is a simple case of PAPVC. Now if we We'll start tracing this case. So I generally prefer to see from caudocranial side. So when you are going from below up, you can identify the IVC and the aorta. If the IVC is on the right, aorta is on the left, you know that, mostly it's not going to be a very complex heart disease. It can be, but but if this relationship is changed, there is associated significant congenital anomalies. Now we trace this. This is the IVC. We're tracing it up. It is going into the this is the right atrium. This is the beginning of the LA. So this here is the IVC and this is the coronary sinus. So first the IVC is entering into the RA, and then now till now the LA has not started. So now the LA has started here, and we are seeing that there is a lower lobe vein draining into the LA, and we go up, we have another vein draining into the LA. So this is on the right side. So we are seeing all the veins on the right side which are draining into the LA. We're also seeing one vein from the posterior side draining into the LA. So that is the left lower pulmonary vein. But we don't see the left upper pulmonary vein going anywhere into the LA. So we're going to trace it up. If we go up, it is going superiorly, and we trace it further up. You can see the tributaries entering into this anomalous vein. It is going up, further up, and it is draining into the innominate vein, which communicates with the SVC, and then the SVC is draining into the RA. So this is a simple case of PAPVC of the left upper lobe. You can see a 3D very well depicting. So this gives a lot of depth and actual perception of how the vein is lying into the thorax. Okay, so this is the anomalous vein draining into the innominate vein and SVC. So this is an example of PAPVC. Now, if we have a case where there is drainage of the entire one-sided lung anomalously and the other lung is draining normally, it is called hemi-PAPVC. A hemi-PAPVC can be right hemi-PAPVC or a left hemi-PAPVC. Now, this is an example of a right-sided hemi-PAPVC. So we'll trace the pulmonary veins. Okay, so here we are going from superior to inferior. We are going to trace the pulmonary veins. Okay, so we're going to trace them where they are going. So you can see this venous channel, which is going inferiorly, more inferiorly, and into the IVC, which itself is quite dilated. Not seeing any stenotic area within this. So this is a hemi-PAPVC. You can see this which is going into the just into the IVC, but at the junction of hepatic vein and IVC without any obstruction. So this is an example of right-sided hemi-PAPVC infracardiac without any obstruction. Okay, so we go on to the next case now. This is a case of so this is a case of complex congenital heart. Okay, we can look when we are seeing here. You can see that there is a IVC is lying anterior to the aorta. This itself goes to tell you that this is going to be a complex congenital heart disease. Okay, so we are now going to look. There are multiple findings in this, but we'll stick to the pulmonary venous anomalies. So we are seeing the pulmonary veins here. These are the pulmonary veins. You can see the differential enhancement, and there is one area which is common between the right and the left-sided pulmonary veins. So we are seeing the pulmonary veins here forming a channel which lies posterior to this atrium. Okay, this was a case of right isomerism with bilateral right atrial morphology. Okay, but now in this case, there is a vascular channel which is in close association with the atrium. So this is called a common chamber. A common chamber is a vascular channel which lies in association with the left atrium, usually the left atrium. Here it is a rare case, not a rare case, but a case of right isomerism, but it's lying posterior to this atrium. So this becomes a common chamber. This portion is not called the vertical vein. So the portion of the vascular confluence which lies posterior to the atrium is called the common chamber. This is what I want all of everybody to understand. Okay, and then it continues further as a vertical vein or a common vein. It can go superiorly or it can go inferiorly depending on supracardiac or infracardiac TAPVC. So this is the common channel vertical vein, which is going superiorly and then draining into the innominate vein. And then there is a left-sided SVC, which is draining into the left-sided morphological right atrium. Okay, so this is a case of TAPVC. Again, there is no obstruction. You can see the vein very commonly, very nicely on the map image. So you can see that there are three veins here. We were not, I can't put all the three in on the same map image, but there was bilateral right lung morphology. So this portion becomes the common chamber. Now, this is a cardiac type of TAPVC. Now, in cardiac type of TAPVC, there is drainage of the veins into the coronary sinus, or it is draining directly into the right atrium. Now, this is a case where all the veins are draining into the coronary sinus. So, coronary sinus invariably opens into the right atrium. Okay, there is no ambiguity over there. So now, if you see, there is this is the common chamber. There is a common confluence of the right-sided veins and the left-sided veins. You can see the veins nicely. And this is the common chamber. We call it a common chamber because it is lying posterior to the LA. Now the LA is small in size. It is small because there is no flow going into the LA except from this ASD. Okay, so right heart is be dilated, left is going to be small. So this is an example. If you see now, this is a it forms a once it forms a common chamber, it will continue inferiorly as a common venous channel. Now, if you see, this is the coronary sinus. This portion is the coronary sinus, and this is the common vein which is entering into the coronary sinus. So this is a cardiac type of unobstructed TAPVC. You can see the amount of plethora in the lung which is there, which is common with TAPVC because there is increased increased right heart, right-sided circulation. Now, this is an example of an infracardiac TAPVC. Okay, so you see this. Now, again, we are going from above below. Now, first here only you can see that the arch is little smallish in size. Okay, now this is the MIP image which is showing that the arch has lost its normal candy cane kind of appearance, a normal sharp U that is there. It has become more stretched and elongated. So this is commonly seen with TAPVC because of poor forward flow from the left ventricle. Okay, then we are going inferiorly and we are seeing again there is a common chamber. This is the left atrium. So now if this is lying in close association with the atrium, this becomes the common chamber. So the common chamber is quite small in size. You look at the size of the vein and you look at the size of the common chamber, it is little small in size. Okay, so we are not dealing with something which is very good size common chamber. So these patients are likely to have recurrent restenosis post procedure, post surgical correction. Now this is the vertical vein which is following from the common chamber. That's okay. So we go down. This is the vertical vein which is going further. And then you see again there is a tight stenosis here. So this is an obstructed TAPVC. And then the vein is going up and draining into the hepatic vein IVC confluence. So this is an obstructed kind of infracardiac TAPVC. Again, lot of plethora in the lung, pulmonary hypertension, edema, all those findings are there. Okay, plus there is a small PDA and a smallish arch which is there. Okay, so these are all findings you will see in a TAPVC. So the reporting points that you must mention in the case of anomalous pulmonary venous connection is whether it is TAPVC or PAPVC, then whether it is supracardiac, infracardiac, or mixed, then whether it is obstructed or non-obstructed. Presence of common chamber is important to be mentioned. Also, if you have multiple tributaries draining into the vertical vein, you need to mention that so and so portion of the lung is draining through multiple tributaries into the vertical vein, especially when the common chamber is not there, because then it becomes difficult to correct such a anomaly. You may need to give the length of the common vein, especially if it's infracardiac. Size of the pulmonary arteries is important because most of these patients will have pulmonary hypertension and PAs may be enlarged and dilated. Now, invariably when PAs are dilated, you must look for the tracheobronchial tree for any kind of compression. If there is a bronchial compression, again, it is an important finding as a pre-op, important finding pre-operatively, because these patients may have difficult extubation later on. So the counseling and risk that you assess the risk pre-operatively depends on that. Pulmonary vascularity will be increased. Sometimes there may be differential vascularity. You must look at the aortic arch without fail. So these are some important reporting points that you must remember. So of these, presence of common chamber, tracheobronchial tree compression, obstruction, these are important findings. Another one which I've not mentioned here but is important is presence or absence of spleen, especially in heterotaxy and right isomerism. The spleen may be absent, or spleen may be in the form of multiple tiny splenuncula with no definitive splenic tissue. So these patients may not recover very well post-op. So that also, it's a very easy thing to diagnose on CT, but it's very important for a post-operative stay or post-operative course of the patient. So that must be mentioned as an important point in your report. So as we saw all the cases of TAPVC, various anomalous connection, this is a case where there is restenosis following surgical repair. Again, we are going down. This patient had a TAPVC repair done. Now, if you see, this is the common chamber, which has become very small. This was not that small earlier. And then if you see the still image, you will see that even the orifice at which it is communicating with the LA is small in size compared to the fact that all the veins are draining through a single orifice. So this is restenosis. One thing I'd like to mention here is that the pulmonary veins are very vulnerable to stenosis. So the moment these veins are touched, they are likely to undergo some amount of fibrosis. So the surgeons don't want to touch the veins. So they just want to deal with the common chamber as far as possible. So because every time the veins are touched or they are manipulated, their chances of stenosis goes on, increases significantly. So they don't want to they don't want to interfere with the veins. So that is why the presence of common chamber becomes important. If there is pre-existing venous stenosis or small size veins or a pre-existing common chamber which is small, then the prognosis has to be explained to the patient accordingly, because the chances that the patient will benefit from the surgery goes down. Okay, so this is an example of post-op evaluation. Next, so after completing these, let's go to sinus venosus ASD. This is actually a atrial septal defect which is very close um, to the SVC or IVC insertion points, and there is an anomalous drainage of vein of the pulmonary vein across this ASD. So let's look at this case. This is a case of, I think this was superior sinus venosus ASD. We are going from below up. Okay, so now you are, let's go from up below. Okay, so this is a left-sided SVC. Okay, yeah, that's a left-sided SVC. This is a right-sided SVC. If you have bilateral SVCs, do mention if there is any venous channel communicating between the two. Okay, so here there is no venous channel communicating. And now we'll trace the right SVC. If we trace the right SVC down, we'll see the pulmonary vein is draining into the right SVC above the SVC-RA junction. And we go inferiorly at the SVC-RA junction, there is a ASD which is there. So you can see this superior sinus venosus ASD and anomalous draining pulmonary veins. Okay, there are multiple veins which are draining anomalously across the sinus venosus ASD. Some of these can be corrected by intervention in adults, but not in pediatrics, because you can't put in a stent graft in a pediatric patient because their child will grow. So the stent graft is not an option. But for adults who come with this kind of anomaly, intervention procedures can be done. So this is sinus venosus ASD. You have to mention the size of the defect and the pulmonary veins which are draining along the defect, as well as if there are any additional pulmonary veins which are draining into the corresponding SVC. So that also needs to be mentioned. Yeah, again, you can see then other findings of dilated right heart, pulmonary hypertension, all those will be present. Then next we will go on to isolated pulmonary vein stenosis. This the case I'm showing is congenital, but these can also be acquired after an ablation procedure. So many times patients with atrial fibrillation undergo MACE procedure where there is radiofrequency ablation done around the openings of the pulmonary veins. So many times these can lead to osteal narrowing of the pulmonary veins. It's not very common, but it can happen. That is an acquired pulmonary venous stenosis in adults following a procedure. Okay, so here is an example of isolated pulmonary vein stenosis. So we'll trace it from above below. We're already looking at a very dilated pulmonary artery. So these patients usually come to us with complaints of pulmonary hypertension. So one of the causes of pulmonary hypertension, which you need to identify as a cause, would be pulmonary vein stenosis. So here, if you see, you can look at the pulmonary veins on the left side. Now, this is the left-sided pulmonary vein. You can look at it as it's very, very small in size. Okay, it's hardly any orifices left. So this is very tiny, very tight stenosis of the left-sided pulmonary vein. If you look at the left lower pulmonary vein and we go up, it is almost occluded. It's almost occluded over here. So this is isolated pulmonary vein stenosis. We didn't have any cause for this, but the right-sided veins were normal. Okay, if you see the veins on the right side, they were fine. It was only isolated left pulmonary vein stenosis. Now, if you see in this patient, you can also see that the vascularity is kind of, you can appreciate, I can appreciate there is much less vascularity on the left side compared to the right side. I needed another MIP window for this, but there will usually be associated low vascularity on the side where there is congenital pulmonary stenosis. So that we often see. Okay. This is another example of isolated right-sided pulmonary stenosis. So this is the right-sided pulmonary vein, and you can see very tight stenosis of the upper vein, and it was draining through a common orifice into the LA. So this orifice is also quite stenosed, and this was again poor vascularity on the side of stenosis and increased vascularity on the other side, which you will see. These are causes of pulmonary hypertension. So whenever there is a workup done for identifying a cause for pulmonary hypertension before labeling it as idiopathic, a CT angio is often done. And you must remember that pulmonary vein stenosis is one of the causes for a idiopathic pulmonary hypertension. Now, this is another case of pulmonary AV fistula. These are quite rare. But this is a interesting case of a very large AV fistula. So we're going from in caudocranial direction. This is the LA. Now, this is the pulmonary vein. If we see, there is dilatation of the pulmonary vein. As we go up, you can see a large fistulous tract over here. You can go up, and then it is seen directly communicating with the left pulmonary artery. So this is a large AV fistula which was there. You can see it communicating between the pulmonary artery and the pulmonary vein. This is quite rare, but you can see the amount of dilatation of the left-sided pulmonary artery compared to the right. So these patients can also have isolated one-sided pulmonary hypertension. The right may be okay, the left may be hypertensive. Here again, we need to give the size of the fistulous tract beforehand. So then you can identify whether these can be closed with a device or they need to be operated. So do we need a surgical closure, or we can do it by intervention? So CT can play an important role in that. Now this is the same patient after device closure. So it was a very large device. We did have a lot of discussion whether device closure would be possible. Luckily, we could do that. Our intervention people could manage to put in the device, and then there was only isolated dilatation of the vein, which we hope that it will subside with time. But the fistula tract was completely gone. So this is a case of pulmonary AV fistula. So now we'll just come to wrap up the whole thing. We know that CT can be used for surgical planning or whether you need to do intervention. how much you need to intervene, and follow up imaging. In all cases, CT would play an important role, and MR we would leave to identifying the amount of shunting that is required. So these are the common conditions. And before I end, I would just like to mention that in your reports, do mention pulmonary venous stenosis. Do mention if there is a common chamber or no. Do mention if there is an aortic arch anomaly and tracheobronchial tree compression, splenic this thing, whether spleen is present or no. These are like few things which actually impact the outcomes of the patient and help in patient management. So this is all that I need to say. I'm open to taking any questions, and I really thank all of you, and REF to giving me this, and ICI to give me this opportunity to speak to all of you. Thank you.
Thank you, ma'am. Thank you so much. On behalf of everyone who was listening, I can assure you this will be a most simplified version that we have ever seen or heard about pulmonary venous imaging. Thank you so much, ma'am. Should we take questions?
Yes, please.
Okay. So the first question is there anything called as dual drainage?
Dual drainage of the same chamber of the same portion of the lung draining into two separate things.
Maybe he's
I'm
asking
not,
about like coexisting supracardiac and infracardiac PAPVC
that
lines.
would then fall into the mixed variety. I'm not sure in dual drainage. I'm not sure. I'm not reported something like this, I guess.
All right. So another question is, can we get exclusive pulmonary phase and coronary arterial phase? What should be the protocol and time?
So isolated pulmonary venous phase is very difficult to get because there will be a ASD, there will be some other congenital. You're not going to be dealing only with the pulmonary veins, and it's very difficult to time it like that. I would say that if you're going to do two runs, first ECG gated and a second non ECG gated, you will get a differential blood flow in the veins, and you will be able to identify the veins separately from the arteries. Okay, so at least in the arterial phase, you will be able to see. Sometimes, if it's only a PAPVC, then the first ECG gated phase will show you the pulmonary veins pretty well. But other, if it's a complex congenital heart, then you will have to rely on the venous phase, but it's difficult to separate. So the protocol generally is that you inject through a lower limb vein, and and you start the uh, first run will be cranial. We take it craniocaudal, but I think machines vary in their rotation speed and pitch and everything. So it will and how much delay time is available. So that becomes variable. You'll have to figure it out. But for us, we're using a Siemens, so 128. So in that, we run craniocaudal for the first run, and the second is caudocranial. So that gives us pretty good images. First ECG gated only up to the diaphragm, and then caudocranial we cover from just below the liver margin up to the entire chest. That is usually is sufficient for getting all the information that is needed, and I think it should work for most cases.
And would that be bolus
GE
stacking?
perhaps
Where
doesn't.
would you put the
We do
hello?
bolus tracking. So in the previous CT, we used to keep it into the more into the RV, but now the moment we see some blood, some contrast coming into the cardiac chambers, we start because the machine has its own, it has a certain delay time which we cannot change, and uh, the time to
Some
for the
unpredictability
table
there.
to
So
move also
mm,
counts. So that is why. Now, that will have, I think it will differ for different machines. So we keep it, we start immediately when the contrast enters any of the cardiac chambers, we start. So that is what we are doing now. Earlier, we would wait till the RV was kind of opacified, and then we would start. So you really need to assess your machine, how it works. So in G, when I worked, I didn't do ECG gating because ECG gating didn't give me good images at all. So I did two runs without ECG gating. So I think it's highly variable for one protocol to fit everyone.
all right, ma'am. Next question. Can you please summarize all cases in 5-10 minutes for revision? Thank you, ma'am, for this wonderful talk. I think we can take this question later on if we have time. Moving on to next question. Main pulmonary artery size is normal. When to say dilated on CT? Maybe he's asking normal dimensions of pulmonary artery.
So in a
Hello.
child, you can simply use the Z scores. I think those are the best available tools. You just need to put in the height and weight of the patient, and based on that, you will get more accurate findings of whether the pulmonary arteries are dilated. If so, how much dilated compared to the normal. Otherwise, aorta and pulmonary artery sizes can be compared. Particular size measurement to give for a particular child is difficult because they are all variable in their growth and their weights, and whether they are preterm, or they are no at term babies. So all that becomes very variable. Best is to go with Z score. That's what I feel. For an adult, though, it would be comparing the aorta and PA sizes. That is most standard. I think that helps the most. Otherwise, you just stick to Z scores. You can go to parameters.com or you can go to PEDC. PEDC is also another site which will help you getting the Z scores. They are all free tools available online. You should make use of those.
On CT, a small vein is seen lateral to the arch of aorta. Which is that vein?
I sorry, I
Okay.
didn't get you.
On CT, a small vein is seen lateral to the arch of aorta. Which is that vein? I
Lateral
think
to
it's,
the
I think arch of
azygos.
azygos. Moving on, next question. Coronary sinus, where to look on CT?
Okay, so the coronary sinus goes along the inferior surface of the left atrium. It is a venous drainage of the heart, and it always opens into the RA. There is no ambiguity. Suppose you can't identify the chambers by the appendages, just look for where the coronary sinus is opening. Let me see if I can open one of the cases and see if I can show a coronary sinus such. One second. I'll just give me some time. I'll see if I have some normal adult case where I can show. But the coronary sinus, the best place to see is you can see it below, inferior to the left atrium, at the atrioventricular groove. Just at that level, you will see it opening into the RA. That's where you have to look for it. Any other question?
Yes, so one compliment. This was such a great presentation. Please, ma'am, take more topics. Sure, I can assure them from your on your behalf. Uh,
Thank you.
Ma'am, can you please explain sinus venosus ASD again?
Okay, so sinus venosus ASD is basically an atrial septal defect with a pulmonary vein draining across the atrial septal defect. Should we go back to the case which we had shown? We'll go back to the case and see it again.
Yes,
Am I sharing the screen already?
yes, yes, yes.
Okay, good. Okay, so we'll see in this case only. So now we are seeing this is the left atrium, this is the right atrium, this is the triangular appendage. So, and this is the interatrial septum. Okay, so when we are tracing the interatrial septum, you can see that there is a septal defect here. Okay, there are various mm, okay, I'm just getting distracted with some with other comments. But okay, so this is a atrial septal defect. Now you can see the pulmonary vein. Now this is one pulmonary vein which is draining on the right side of the interatrial uh, septum. Okay, so this if I have to show you again. Okay, so now you have the interatrial septum going up, and we are seeing the septal defect, and you're seeing this vein draining more into the RA. Okay, so this is the, and this will, if you go up, then this is the SVC. So it is invariably a combination of SVC a pulmonary vein and ASD, all three draining into the RA. There is a septal defect, there is a pulmonary vein which is anomalous, and the SVC, or if it is inferior sinus venosus defect, then the inferior vein, the same finding but inferiorly, where the IVC is communicating with the RA, there the defect will be there. So this is a sinus venosus defect. Um, so you need to mention how many what now this one is draining into the LA, but this one is draining across the ASD. Sometimes you it just drains across the ASD. It may not be definitively into the RA, but there will be a combination of these three things: the entering of the vena cava, the absence of the interatrial septum at that side, and then anomalously draining vein. So that's a sinus venosus defect. Um, any particular question, any particular doubt that you have regarding sinus venosus ASD, which is confusing, then maybe I can point out that, or this helps you.
I think it should suffice as of now because one another person also has asked, can you show the sinus venosus defect? So we just did that. Somebody has asked MPA and right left pulmonary artery normal size. That also has been taken. Is there any cutoff value for pulmonary vein stenosis?
No, there is no cutoff value. Many times you will see that the pulmonary vein opening looks very tiny, but there is no gradient on the echo. So if there is no gradient on the echo and the pulmonary orifice is still looking like very small, you can just mention it that it is small in size. Don't mention that there is stenosis. Okay, a common thing would it will help you to say that there is stenosis. There is dilatation of the rest of the vein, like the vein distal to the stenosis is dilated. So that you can use to say that there is pulmonary stenosis. But otherwise, first check on the echo. Is there a gradient? There is no gradient. If there is no gradient, you're still seeing that the vein is very small in size. You just mention that the vein is small in size. There is no cutoff for a pulmonary venous ostial measurement because you don't know how many veins are draining through that particular vein. Now, if the RA of the right lung is draining through three separate veins, then the three veins will have a different orifice. But if all three veins are draining through a single vein, then that vein is going to be bigger in size. The orifice needs to be bigger in size. So you can't put in a particular label, but the important factor is on the echo if there is a gradient. That is kind of a flinching thing. If the orifice looks very small, maybe 2 millimeters or so, but there is no gradient on the echo, then probably that is not significant. Significance is only when the pressure gradient is present. So you must correlate what you are seeing with what you're seeing on the echo. It cannot be an isolated finding. Okay, but in the case which I showed you, it had a definite long segment narrowing, and then there was dilatation of the veins on the distal to the in distally in the lungs. The veins were dilated. Plus, there was a discrepancy in the flow between the right and the left lung. So that case doesn't become any. There is no ambiguity in such a case that okay, yes, there is pulmonary venous stenosis, but those cases will invariably have a gradient on the echo. So don't go particularly by numbers. Okay, so have a thing where you are more clinically inclined to identify, okay, is this the real problem that you're looking for? Otherwise, you'll see many pulmonary veins which look very, very tiny. Sometimes the pulmonary vein orifice is small, not because they're stenosed, but because the arterial supply to the lung is low. Like in tetralogy of Fallot with pulmonary atresia, the flow in the lungs itself is so low, pulmonary veins is going to look small. So then you can't assign a particular number to it. So don't go by that. Look for the gradients and then correlate findings with what you are seeing on the CT. Does that help?
Kindly advise, yes, yes, definitely. Kindly advise resources for studying and learning cardiac imaging for residents.
I think we have a textbook which we have come up with for congenital heart diseases. I think that's a very comprehensive textbook. Maybe people can refer to that. Otherwise, I think I really don't know. Most of things are available online. There are so many resources online, articles online. In today's day and age, I think there's no dearth of information.
Yes, okay. Yes, the book that has been written by all the eminent